Hello all. Greetings from the team Prevent It. I'm Dr. Donna and I will be the moderator for the webinar. Prevent It is a 3-year project co-funded by the Erasmus Plus program of the European Commission. The vision of the project is a future where every individual is aware of ABR or the antibiotic resistance and is empowered with the right education to address this issue. Antimicrobial resistance is a global concern. Recognizing this, the World Health Organization made a call to celebrate World Antimicrobial Awareness Week every November to increase the awareness on AMR and to encourage best practices among the general public, health workers, and policymakers. The theme for the year 2020 is United to Preserve Antimicrobials. In this regard, I welcome you all to today's webinar on the same theme. I am pleased to welcome our special guest, Dr. Jyoti Joshi, as the speaker to this webinar. Dr. Joshi is the South Asia head of the organization, the Center for Disease Dynamics, Economics and Policy. She is also an adjunct professor at the Amity Institute of Public Health, Noida. She received her master's degree in community medicine from Lady Hardinge Medical College and Masters of Science degree in infectious diseases from the famous London School of Hygiene and Tropical Medicine. She co-authored the scoping report on antimicrobial resistance in India. She was the Asia lead for the Global Antibiotic Research Partnership Project, wherein she was instrumental in developing and implementing AMR national action plans across various Asian countries. Today, Dr. Joshi will be sharing her views on United to Preserve Antimicrobials. Ma'am, next slide, please. After attending this webinar, attendees will get an overview on antibiotics. They will also be able to understand about AMR, the current and future scenario, and the drivers of AMR. They will get insights into various efforts taken to preserve the antibiotics. Before starting with the webinar, I have a few instructions to the audience. The webinar is being conducted on Zoom and we are directly streaming it on YouTube. Please feel free to type your questions in the chat box. Please begin by typing #AskPreventIt so that we will understand that these are the questions you want to ask our speaker. We will try to address all the questions during the last 15 minutes of this webinar. Additionally, to make the session more interactive, we are conducting live polls. All the Zoom attendees will be able to participate in this online poll. I would also like to add that this webinar is being recorded. The recorded session will be posted on the official website of Prevent It and also on the social media web pages of the project like Facebook, Twitter, and LinkedIn. And last, we would like to encourage you to share the webinar within your social network. So without any further ado, I would like to welcome our speaker, Dr. Jyoti Joshi. Over to you, ma'am.
Thank you, Donna. And hello, everyone. It's my pleasure to be here at the start of the World Antibiotic Awareness Week and discuss antibiotics and their preservation with all of you. I'm coming to you all live from Delhi, and amidst the COVID pandemic, the preservation of our antibiotics becomes even more critical. So basically my slides will, after having a round of introductions between us and CDEP, the organization where I work, will be divided into two parts. I will first be talking about giving a brief introduction to antibiotics, the epidemiology of their use, and then the scale and nature, as well as this current status of the antibiotic resistance problem. Then in the second half, we will discuss efforts to preserve them for the future at both the global level with some focus on the country that we are living in, which is India. And hopefully all this will take us to the future direction for how antibiotics can be preserved for future generations. So I come to you all from an organization called the Center for Disease Dynamics, Economics and Policy. I'm based at the Delhi office. We are a research think tank, which is based in Washington, DC, and has offices in New Delhi and Nairobi. We do a lot of policy and data analysis and produce impactful evidence-based report on topics related with infectious diseases, in which vaccines and antimicrobial resistance as well as zoonotic diseases are a big part. So I welcome you to go and explore the CDEP website. And additionally, for antimicrobial resistance, I would like to highlight, we have a site within the major subsite within our website is resistancemap.org, where we provide freely available data on the status of antibiotic resistance as well as consumption for humans and animals throughout the world. I will be referring to a lot of those slides today and maps, but I welcome you to go and explore and keep learning about what's happening to the problem from this website. So coming to the topic, what are antibiotics? So basically, antibiotics are chemicals that kill or inhibit the growth of other microorganisms. These microorganisms could be, as we will discuss, bacteria or fungi, but we are concentrating on bacteria, so we are talking of antibiotics. Now, these chemicals could be coming from either natural sources like the fungus penicillium for penicillin. They could be semi-synthetic compounds, which are like derivatives of some natural compounds, or it could be totally synthetic chemicals. They could be oral or parenteral, that means given from the mouth or taken through the IV, intravenous or intramuscular route. They could be narrow spectrum, that means they work on only a few targeted antibiotics, bacteria, or broad spectrum. That means they carry and have action on a large range of bacteria. These characteristics are important for us to know as we talk about antimicrobial resistance. More importantly, how do these chemicals act? So I'm not a microbiologist. I'm going to be talking to you from a very public health perspective, but I think it's important to understand the mechanisms of how they act. So basically, antibiotics will act by either stopping the entry of the particular bacteria in, breaking the cell wall or cell membrane of a particular bacteria, or they will act on the protein synthesis and the nucleic acid synthesis part of that particular bacteria by breaking it up and not allowing it to replicate. There are certain antibiotics which could also block the pathways of metabolism and prevent further growth. So depending on all these actions, we have different classifications. Once we know all these criteria of how antibiotics act, what should we know as epidemiologists? We have discussed what they are, how do they act, but when should they be used? Ideally, vaccines are a part of prevention for antibiotics, but when we discuss the illness, the things that we are giving to prevent it is antibiotics. When should they be used? When either the patient has a symptom, which could be fever or a runny nose or a cough that is not going, or a sign that the healthcare worker or a doctor thinks could be due to an infection. But remember, these signs and symptoms, like cold or cough, like I discussed, or even a visible lesion in the skin, which only the healthcare worker detects, are only grounds for suspicion. These are empirical. The need for a bacteria to be confirmed is critical for the use of an antibiotic. And how do we confirm that diagnosis? Is only through the laboratory or the lab, which it could just be a specimen example to do a qualitative analysis, whether the bacteria is present or absent, or a detailed quantitative assessment to see whether it's how much of that bacteria is present and to what antibiotics it is resistant by culture or sensitivity. But remember the key message, an antibiotic should only be used when we have a confirmation of a bacterial disease or a cause for that particular illness. Who should be using these antibiotics and why and where? So antibiotics should be used to treat anyone who's sick. And remember, these are drugs which could be used for sickness in human beings as well as sickness in animals. But who are the people who should be prescribing them? Are those who have the license and the training for it. which are basically doctors, could be general practitioners or specialists, and animal practitioners or veterinarians. It is not you and me, which is who should be taking the antibiotic like a vitamin. There is a stark difference in how antibiotics are currently used to how they are actually supposed to be used. And that, my friends, is the big reason for antibiotic resistance, as I will discuss with you further. So Paul Ehrlich, one of the discoverers of one antibiotic for a urinary tract infection and a sexually transmitted infection like syphilis, had very nicely said at the beginning, drug resistance follows the drug like a faithful shadow. Now, this saying at that time was in relevance to the anti-cancer tolerance that was developing for cancer drugs, but it was true also for antibiotic resistance. Because the more we use antibiotics, the greater the exposure of the bacteria to it, and the greater their capacity to innovate and ability to survive in spite of the antibiotic. So, what is antimicrobial resistance? Antimicrobial resistance occurs when a microorganism, which could either be a bacteria, a virus, a fungi, or even a parasite, it changes in the way that the medication that was used to treat it is no longer effective. And amongst these range of antimicrobial resistance, it could be antibacterial, antiviral, or antifungal properties. It's the antibacterial resistance which is most critical and worrying, because antibiotics or antibacterial resistance doesn't impact just people when they are sick because of a particular disease, but when people are even sick from in the hospital for just a surgery or just a joint replacement, which is happening very commonly these days, or an anti-cancer therapy, and they go in without an infection. If they are caught with a bacterial infection which is resistant, in spite of not having suffered an illness earlier, they will be bothered by antibiotic resistance. So remember, antibiotic resistance is not just about communicable diseases or infectious diseases alone. All people who suffer from non-communicable diseases are at greater risk for antimicrobial resistance and thus communicable diseases. So it's not a world of one or the other. Both the worlds or both the disease burdens require antibiotics. And thus handling or tackling antibiotic resistance becomes very critical. Like I was telling you, how does this antibacterial resistance occur? It basically occurs through gene transfer. There could be many mechanisms, which I am not going into again in detail because I am not a microbiologist. But yes, you can think of it as a pond where the bacteria which is exposed to the antibiotic initially will respond to it, be sensitive to it. And some of them, through their genetic mutation, would develop resistance and survive. Now, because the antibiotic is existing in the medium for a long time, those selected bacteria which are resistant and can survive will be the only ones left for a while and will continuously multiply. Once they multiply, they will circulate, and they will circulate not just in the host where they cause infection, but through his or her discharge, whether it's through the nose, whether it's through the urinary tract or the feces, they will enter the environment. And through the environment, they'll be circulated back to the host, which could be an animal or a human being. And thus, antimicrobial resistance will continue to be a problem as it circulates. Now, what is the scale of the antibiotic resistance problem? It's been predicted. It's very difficult to make estimates or understand from studies, by designing studies, that what is the exact burden of antimicrobial resistance. When a person is suffering or is lost due to antibiotic resistant, the diagnosis that is written in the death certificate is not that it is an antibiotic resistant infection. It is usually written as underlying illness like a diabetes or a myocardial infarction, the incident that happened. So very tough to estimate. But based on modeling, it has been found that today the burden of AMR on a lower side could be 700,000 deaths annually, but it is expected to rise to 10 million deaths by 2050. And mind you, this is the largest burden, more than even cancer or any other non-communicable diseases, and should not be acceptable. So thus it is an emergency today, and unless we act on it, we are going to suffer the problem for a long while. Where will all these 10 million deaths occur? You can see from this map that the larger burden will be in the Asian subcontinent with almost 4.7 million deaths. Remember, the populations of India and China are much more than the world, and thus we will suffer even more the problem of mortality due to antimicrobial resistance. Not just that, it's not about one country or one area or one continent addressing AMR. This slide very nicely shows you how bugs travel. Superbugs, which are resistant bugs, don't need visas. They don't respect borders. They can move from one traveler who could be a tourist or attending a seminar, or just one product, which could be the food material or the animal product that was transferred from one place to the other. I think now that the scale of COVID has hit us, we should understand that superbugs or even a resistant bacteria could not be controlled and kept in one particular region. It will soon or later travel and has to be tackled immediately by all together. And it just affects every part of our population. Almost 56,000 newborn deaths occur due to sepsis, which are resistant causes of sepsis, which occurs due to resistant causes. Now, you can also see in the other graph, so we are using even newborns who are born without any infection, but the environment or the host factors when they are born from the mother system exposes them to bacteria, which unfortunately are not sensitive to the drugs that we give them. Similarly, in the map that I'm trying to show, the bloodstream infections due to colistin resistance, Klebsiella pneumonia. Remember, this is a bloodstream infection. So people who have been lying in the hospital, who are sick for a long time, are going to suffer from this. And if they are causing almost 69.3% mortality, almost 70%, only 1/3 of them or less than 1/3 of the patients are coming back from hospitals, which is a scary perspective for our hospital-acquired infections. I've talked about this slide here. So this is one of the publications which you can refer to. So here I'd like to pause and ask you by recalling why antimicrobial resistance is a big problem. By 2050, what is the estimated number of deaths that are expected by antimicrobial resistance?
The Zoom participants can start giving your polls. And I think we have around 189 participants. So please.
There is good participation, Donna.
Yes, yes, ma'am.
I think we can pause now.
Okay. Yeah, sure, ma'am.
It's good to see that most of the answers have been correct, but a lot of people have also been confused. So I would like to highlight that it is 10 million deaths that are expected by 2050. 70,000 is the current low estimate scenario. It's 10 million by 2050. Should I go to the next slide, Donna?
Yes, ma'am.
So now what are the drivers of antibiotic resistance, like I was talking? The more the antibiotics, the more the bacteria is exposed to the antibiotics, the greater will be antimicrobial resistance. So how is that exposure occurring? It's occurring by the consumption of antibiotics in the world. So here you can see a map which shows the antimicrobial consumption change since 2000 to 2015 over that 15-year period. And you can see that the larger red colors are changes in daily defined doses of antibiotics are occurring in the developing countries, whether it's Brazil or India, Russia, China. The consumption pattern is increasing. And where is it increasing? Like I showed you, it's higher in the lower income or in the upper middle income countries. In fact, the recent study, which is the Ailey's paper from 2018, it shows very nicely that there is actually a 4% decrease in per capita consumption in the high income countries because there is strict regulation and enforcement of that regulation. But in low and middle income countries, we have seen a 39% jump. And there is a gradual convergence at the level of use in antimicrobials. Now, is that a good scenario? It is scary. Remember, antimicrobial dispensing in our part of the world is on paper very strict, but it is available whenever you and I go. But the implications of this use are worrisome for us in terms of the mortality as well as the morbidity patterns that we are seeing. What are the peak months of these antibiotic consumption? It's interesting to see that the peak month for India is September. That means this is the flu season when the season is changing and people are, the rainy season has just finished. Infectious diseases, even zoonotic diseases are on the rise. And people are thinking that this could be due to a bacteria or a virus. They're not sure. But because the antibiotic is available, it's purchased and consumed the highest. So this is something that again shows how casually antibiotic consumption is taking place and it will drive antibiotic resistance. Now we've talked about the problem, but remember, we still have a lot of mortality due to infectious diseases. So people in the world overall, especially in the developing or the least developed countries, need access to antibiotics. Even today, the mortality due to lack of treatment is much more than than resistance per se. Here you can see the rates of mortality in HIV negative children. This is pediatric mortality due to infectious diseases. And you can see the whole of the developed world could be in blue, but countries like India or even countries in Africa are in red. India is in yellow. So we still have almost 25 to 100 children dying of every 100,000, which is something which shows that we need to use antibiotics, but it also highlights that we need to continue to use it prudently so that the sensitivity of the bacterium to those antibiotics stays and such infections like neonatal sepsis can be prevented. So for policymakers, when we talk about antimicrobial resistance, as we will discuss in the response, it is a challenge to balance access of effective treatment, that means antibiotics at least being available, to the excess, that means unethically available antibiotic, which is casually popped in. Now remember, antibiotic resistance is an invisible epidemic or even a pandemic, I would say. You and I, when we consume antibiotics for a cold which does not resolve in 2 or 3 days, do not know the mortality that it might be causing in another part of the country or another part of the city in a child or an elderly who may have a resistant infection. So it's not just the policymakers, the policies that they make and their implementation by you and us has to be keeping this in mind. But there are other problems. Besides consumption, the problem is there is a poor market in the type of antibiotics that are available. We did a scoping report for the Department of Biotechnology and Research Councils UK, which showed that there are higher end antibiotics like cefixime or even amoxiclav, which are available with large number of manufacturers. But simpler narrow spectrum drugs like benzathine penicillin or dicloxacin are simply not there in the market or have only 1 or 2 manufacturers. Because the market is not sustainable, the cost is too low, or the expectation of a better, newer antibiotic amongst the people and the healthcare system is something that drives the demand. So we have to keep this in mind and make sure that the narrow spectrum, better acting drugs continue to be available and feasible for production. Like I showed you in the first slide, I think I may have positioned this wrong, but you can take a guess here as I show you. Who do you think is the largest consumer of antibiotics? Is it China? Is it India, Brazil, United States, or Russia?
We are getting pretty fast responses for this question, ma'am.
Not something to be proud of, but yes, something to be aware of, definitely.
Shall I end the poll, ma'am?
Yes, I think that's is sufficient for now. Thank you.
Okay, ma'am. Okay, ma'am.
So I think the larger responses have been correct. So almost half of the audience, more than half, has been correct. But yes, it's important for everybody to remember that the largest consumer of antibiotics is India. The per capita consumption may be lower, as I will show, but the total consumption of antibiotics is the highest in India. I'll go to the next slide. And why is that so? Because in addition to the simpler antibiotic, we also have, fixed dose combinations that are available. These are combinations which are not necessarily rational in terms of their action, but they are rational for production or profitability. As a result, you have a combination of, for example, cefixime with linezolid, which is like the last level acting drug for gram-negative infections, with cefixime, with levofloxacin, which is something which is totally not available, because what it will do is it will foster resistance by exposing more and more people to the particular drug, and those people will be using such a high-end drug for a small casual infection, making that infective pathogen resistant. So we have to use fixed dose combinations very rationally, and thus now many fixed drug combinations have been banned in India based if they are irrational in terms of their mode of action. So the social factors that drive antimicrobial resistance are true for most of the developing countries, and even developed countries are the practice of self medication in the general population, the reason of availability of access without prescription, the use and the knowledge of informal healthcare providers. Remember, we discussed access to antibiotics is itself a bigger challenge. So we are encouraging health workers to give the first dose antibiotic on suspicion. So this empirical use tends to drive antibiotic resistance. But till we have good diagnostic facilities available, it will be a challenge to balance the access and excess bit. Moreover, healthcare providers in either the public sector or the private sector have their own compulsions. In the private sector, there is a perceived demand for antibiotics from the patient. And the private sector player is worried that if he or she does not prescribe antibiotics, or even if he waits for a diagnostic test, the test might be too expensive, it may not be of good quality, or the result may not come in time that the patient is willing to wait, he or she will prescribe that drug to be taken. There are economic incentives, and there is a lack of knowledge for the healthcare provider. It's only the pharmaceutical representative, who's reaching him or her with the newest combination that they have, rather than the technical updates from their peer group or from literature for which they may not have time to read. In the public sector, these demands are true, but they also have a very high patient load, and they have a short supply chain. So sometimes there is short expiry drugs which have to be finished. So they are just being prescribed irrationally just because they are there and they have to be finished, and they are answerable for that stock. Moreover, there is lack of diagnostic facilities. They might have at least a physician, but a lab specialist may not be available, or sometimes the reagent may not be available. So the patient can't wait to prescribe and take an antibiotic, and the doctor is forced so that there is recovery and reassurance of the patient recovering. So these drive antibiotic use, but that is one part of the problem. Now I would like to focus on the use of antibiotics in animals. Today, like I told at the beginning of my presentation, antibiotics are used for sick animals. But we will discuss here how it goes beyond treatment for sick animals. Today, the biomass of animals that are raised for food, mind you, that is farming, is much more than the biomass of humans, our population, and the wildlife combined. Now, this is a startling fact. But what is even worse is that 73% of the antimicrobials that are sold on Earth are used primarily in animals. And a large part of them are used for growth promotion, which means that they are given in suboptimal doses. That means they're not therapeutic, but lower than the therapeutic doses to increase their muscle mass gradually and fatten them up. And these are to be done so we have a better looking chicken or animal which is better resilient to provide the milk or the fish or the prawn, so that in a quicker time frame. And these are substitutes, or let's say like fire extinguishers, for good hygiene measures which would otherwise have resulted in an infection from the surrounding area, because the animal is getting a suboptimal dose of an antibiotic. It will be a better looking animal. It will also have some resistance to the infection. So this is a startling fact. The global consumption of antibiotics in food animals is really worrisome. This is a heat map again by CDEP, and you can see here the red areas that are lying in, again, the developing world. India is red, plus there is red color on the southeast coast of China, and there are hotspots in Latin America. So this shows that antibiotic use in farms is occurring. And at this moment, you can also see that Europe is red to a large extent. But following this report, and now a lot of initiatives are going on in Europe and US, where animal farming occurs for exports, to handle antibiotics with care. And that's why all countries, including India, are addressing the problem. What is even more worrisome, that is in 2010, it was seen that China was the largest consumer of antibiotics. Amongst the top 5, India also is the 5th largest country. It's estimated that by 2030, India will move, because our production should increase, economic activity will increase, our antibiotic consumption will also increase. There is a demand for protein. We are addressing malnutrition by providing meat readily to our populations, but that meat is coming at a cost of using antibiotics. So, antibiotic use is a sustainable health challenge, sustainable development challenge, because it's not just the health sector that is using it. It is the animal sector, the food sector, that has to act on it, so that we are able to have animals without antibiotic use in the farm process. Not just for treatment, like I was telling you in growth promotion, how there was one study that was done by the Center for Science and Environment, and you can see that the food mixtures by various companies contain antibiotics in it. So they could be doxycycline or bacitracin, neomycin, even colistin, which has now recently been banned in the countries last year, but it was available as a growth promoter mixed with the feed for animals to be taken, which is something that was worrisome, and that's why the government has banned colistin in feed. Not just that, antimicrobial resistance is driven by consumption in humans, consumption in animals, but remember, we stay in an interconnected world. The bacteria that we take, the antibiotics that we take in, are discharged through our feces and urine, in hospitals, in homes, in workplaces, and enter the sewage. And from the sewage, you can see, unless if they are removed or treated, they will develop resistance to the bacteria that are routinely available. That means the good bacteria in either our bodies or the good bacteria in the sewage, which help to break down the other chemical products. And like I was telling you earlier, resistance genes can be transferred horizontally between bacteria and between different generations, and vertically between different generations of bacteria. So this resistance presence in the environment threatens antimicrobial resistance even further. There is this study by which shows that STPs, that means the sewage treatment plants that receive domestic waste, domestic and hospital waste, or only hospital waste, all had presence of resistant E. coli. It was more in the hospital waste, but remember, antibiotics are being discharged from home. I mean, leftover antibiotics are thrown away in homes, which is something we should be worried about. Not just that, India is a pharmaceutical world. We are the pharmacy for the world today. Along with China, the APIs are manufactured, API or the active pharmaceutical ingredient, I should say, are manufactured in India. So all the pharmaceutical companies or industries that manufacture will discharge some amount of this chemical in their own waste products or the pharmaceutical effluent. And there are studies that show that effluent pollution from antimicrobial manufacturing units is very high in India. As high as the limit is discharged, is as high as what the entire country of Sweden discharges in the year, is what is discharged sometimes in a day from a plant. So this leads us to the issue that even the risk of ESBL or extended spectrum beta lactamase resistant Enterobacteriaceae colonization, and I'm not talking of a disease, but just colonization for a traveler, someone who comes to the country in India, for example, stays here and maintains all the best precautions in terms of drinking RO water, eating food which is not street food, everything in a spick and span, most hygienic manner. 55% of them, when they come to South Asia, and 87% for India, will have ESBL resistant Enterobacteriaceae in their gut by the time they go back. So like I was saying, superbugs don't respect borders. They don't need visas. Even if you have stayed in the best 5-star hotel, used only bottled water, and you have moved around only in places where you are sure to have food which are hygienic, you will still go colonized, not necessarily affected by symptoms or signs, but colonized with resistant bacteria and transmit it further. This is again the pharmaceutical hub environment component that I'm talking. We have more than 40 API manufacturers in India and more than 250 antibiotic formulation companies. Now they are located in different parts of the country. So these are hotspots for the country to look at in terms of managing their pharmaceutical effluent treatment plants, and finally, how they enter the sewage. So the environmental component from the manufacturing becomes critical in these hotspot districts so that the local populations in those areas are not affected very harshly. Amongst all this, when we discuss environment, I think we cannot forget that the living conditions in India, in many places, urban poverty is worse than rural poverty. More than 50% of the population in India does not have access to safe sanitation and disposal of waste within the country. And it's worse in the urban areas like I'm talking. And almost in 80% of the diarrhea the population, the causes of diarrhea are usually viral, but because of the feel of a quick recovery or the lack of availability of other measures, people will use antibiotics. And the use of antibiotics, because of easy availability over the counter, spurs resistance even more. So in the context of sustainable development, when we are talking of scarcity of water, when we are talking of increased income, rising income in our part of the world, as an economy, we are a rising economy. We are also living in a world where we have other problems like pollution. In Delhi, there is low visibility in the days when there is very high SPM in the air, when there is crops are being burned or vehicular pollution is there, and there are heavy metals in the environment. Now, all of these factors interact, and it has been seen, for example, in areas with heavy metals, the chances of resistance genes persisting is higher. So when we say, if we take the local context of a country in our understanding, the scale of AMR becomes even worse and has to be understood as a sustainable development challenge. So if we don't address factors in human sector, animal sector, as well as the environment, there is a chance of the emergence of even worse superbugs. And addressing AMR will not come through isolated measures in one sector. We call this the One Health paradigm. That means we live in an interconnected world and we have to address each sector alone and together so that we have an integrated AMR solution. It's a One Health approach. But remember, consumption of antibiotics is not the only driver for antimicrobial resistance. It has been seen that if you do a correlation of consumption with development of resistance by taking different proxy indicators, I'll go to the next slide to highlight what I'm talking about, you will see a connection. For example, if there is a change in the aggregate antimicrobial resistance used by one standard deviation, the impact that it has on the resistance is marginal. But if we provide good healthcare infrastructure, that means good primary healthcare facilities, good diagnostic facilities, strict availability of antibiotics on prescription, testing available, there is much better control or impact on the E. coli resistance by putting in these measures. So it is not just consumption which is the biggest driver. There are studies which show that is actually by investing in health systems and a healthcare infrastructure, we can get a better solution to tackling antimicrobial resistance, especially in the developing world. Now that gets us to the second part of the issue, which was about the response. Now we know we have a big problem. We know the drivers are in the One Health paradigm. What do we do about it? So it started with different measures that have to be taken in to combat drug resistance. So in 2011, this slogan was launched that we combat drug resistance. If there is no action today, there will be no cure tomorrow. And subsequently, there have been a big global health response, which is now getting translated further into national and subnational responses. So the Global Action Plan, or GAP-AMR, was launched in 2015 and talks about 5 strategic objectives or 5 pillars, which is first of all creating awareness and understanding of what is AMR. And this has to be highlighted not just in the healthcare workers, but in the common population through communication, education, and training. For example, today we are sitting here during the World Antibiotic Awareness Week, discussing the problem of AMR with a population which is not just microbiologists or in the lab. It is you and I as healthcare workers, physicians, students, teachers, veterinarians who have a role. The second pillar is building knowledge and evidence so that we know where we have to act. And to build knowledge and evidence, you need surveillance to understand what is the scale of resistance, which organisms are resistant, how much, where is the problem lying, and we need to know AMU or antimicrobial usage. So where are antibiotics being consumed, for which illnesses, for which places, so that we can mount measures. We need a good infrastructure for laboratories because diagnosis has to be done, and we need operational research to understand how sensitive they stay. Third, the pillar is on infection prevention and control, and that is critical for healthcare facilities by having water sanitation and hand hygiene measures, IPC measures, not just in healthcare facilities, but in animal farms, in the food safety sector, because antibiotics are being consumed there, and having stewardship towards their use. And not just this, these are healthcare or farm-based work interventions. IPC or infection prevention has to work in the community. Today for COVID, you and I are aware about hand hygiene, washing our hands with a sanitizer or soap, making sure we wear a mask. The same thing will help us for antimicrobial resistance. The fourth pillar, which is critical for our talk today, is about optimum use of antibiotics. How do we do that? That is through regulation, by making sure antibiotics are available only when they are needed, and there is no shortcoming or not lack of availability of antibiotics to prevent any illness. At the same time, we have to balance access and excess, and that is best provided by an intervention of stewardship. That means using antibiotics only when we have a lab diagnosis for it or a real reason for it, not just empirically. And this stewardship is not just in human health, but also animal health and agriculture. And the last pillar is about investments in research and development, because though we haven't discussed much, one problem is there have been no new antibiotics over the last 4 decades in the world, ever since the new ones were done. And most of the pharmaceutical companies are moving out of the area of research for antibiotic resistance and focusing, in fact, on the more profitable areas of anti-cancer medicine or antihypertensives, So we have to look at encouraging research in antimicrobial development so that new antibiotics are available, and these investments are safe by keeping them available to populations all over the world in a very tightly managed manner. Now, when the Global Action Plan was launched, at the same time, the Global Antimicrobial Resistance Surveillance System was launched, which is basically a WHO managed system for fostering the sharing of data regarding antimicrobial resistance. It will help us to collect data in a standardized manner on certain drug-bug combinations. So which bacteria, there are 5 indicator bacteria and some indicator drugs. So their combination is observed over a period of time. The data is reviewed regularly, and the trends that emerge are shared on a global basis so that countries can exchange information and share any change in that data and have targeted measures to assess the impact of their interventions. Today, as you can see, this was as of 2017 actually, almost 47 countries have been included in GLAS, and this is constantly increasing. Moreover, since antibiotics have to be used prudently, we need to have some kind of prioritization of availability of antibiotics so we can manage that access debate. So WHO in 2017 came up with a list of antimicrobials for the essential medicine list as per the use that it wants to encourage, which is access antibiotics which are available all the time as first-line treatment for most common infections. For example, amoxicillin for a respiratory infection, it is very useful and simply available, low cost. But there are certain watch category antibiotics which should be available as only if the access drugs either are not effective or a doctor has prescribed and after a diagnosis is keen to give maybe the first or the second choice drug. So for example, azithromycin. There are certain drugs which are effective, which will be good, but they should not be casually used because they are our last resort options. Resistance to them develops very quickly, and if they're indiscriminately used, then they will be lost in terms of their responsiveness. So such drugs, especially the 4th or the 5th generation cephalosporins, are in this category. Now WHO is encouraging all countries to first understand the surveillance of antimicrobial consumption in their countries, and then see that access drugs should be at least 60% of the total drug consumption. So here you can see in many countries where health systems are not that strong, antimicrobial consumption in the watch and the reserve list is higher than the access list. And this is a worrisome trend. So this data analysis has recently been released by WHO and is something that has been released by some researchers. But as data is entered into GLAS, this can be validated with the country reports also. Not just that, countries have to agree that there is a problem and agree to address it together. So we are talking of a global governance system for antimicrobial resistance. And because WHO alone, as an agency that works in the health sector, will not be able to tackle it. So an interagency coordination group was set up by the Secretary General in 2016, and it brought together researchers, country officials, and organizations that work in human health, animal health, plant, trade, development. And together they had a draft terms of reference. They decided what is needed as next step. And they have submitted their mandate to the Secretary General in 2019. They have recommended the setting up of a One Health Global Leaders Group, which is expected to be announced in this week sometime. And then the next steps for global governance will be rolled on so that countries will be answerable in terms of how they're addressing the challenge, and that will bring impetus to the whole challenge of antimicrobial resistance. Essential medicine list I have talked about, so I will move to this slide, which is critical, that the animal health sector sat down with the human health sector. So the FAO, or the Food and Agricultural Organization, together with WHO, has come out with a list of critically important antibiotics, or CIAs as we call them, for human medicine. Now, these are drugs prioritized into 3 categories, which are critically important, highly important, or important. Now, drugs which are in the critically important group should not be used for agriculture, especially for intensive farming. Even the highly important ones are to be used with care, and any use of antibiotics for growth promotion is to be stopped. So the world, including countries in the developed world like US, Europe, and in the developing world like India, many countries in Africa are moving towards this. And for example, colistin use in feed and growth promotion has been banned. Gradually, this list will be incorporated, and each country will come up with a list of preventing antibiotics which are critically important to be used in animals. There are surveillance guidelines for integrated surveillance of antimicrobials and resistance bacteria in both the human health, animal health, and food animals. So the food safety, when the animal is out of the farm, once it's meat, it's no longer a part of the animal husbandry group. So the food safety groups looks at that, and there are harmonized protocols so that everybody is talking about the same bacteria and the same drug bug combination. We don't know how much antibiotics are being consumed by countries themselves, especially in the Southeast Asia. So WHO has come up overall with a antimicrobial consumption tool at the global level. European countries have been using it for long, but this methodology is now going to be used for the other countries also. And that's why it's a part of GLASS. We will have estimates not just of resistance bacteria from the lab, but also of the antibiotics that are being consumed in the world through this GLASS mechanism and this AMC tool. The idea is to optimize antimicrobials at each level, from research and development to their market use. The last slide that I would like to talk about in the pillars is about the implementation of the Global Action Plan for developing new antibiotics. And this is critical.
Excuse me, ma'am.
Yes.
Ma'am, we have 10 more minutes.
Yes, I'm just coming to the last few slides.
Yeah.
So we can do the last.
Okay, thank you, ma'am.
So the GAP implementation has reached the GART-P level, an organization called Global Antibiotic Research and Development Partnership that will help is developing clinical trial networks in our part of the world and helping countries come together to try new chemicals as antibiotics. Initiatives in India, I think I'll quickly skip. These will be available to those who would like to see. This question is for the poll that I would like to ask, but I think we'll skip it for now. The appropriate use for antimicrobials is strategic objective 4, and this is something we must watch for in terms of activities that are implemented. This is again the GAP-AMR. For India, we have a surveillance site network of almost 20 sites by the National Center for Disease Control, which is available on their website. And a lot of action is ongoing for surveillance in India. Remember, the point that I must highlight is the use of vaccines to address antibiotic resistance. If we can stop infections by giving vaccines, then there will be no rise of resistance in bacteria itself. One of the key exciting vaccines is the pneumococcal conjugate vaccine, which it has been studied and has shown, for example, in the US, that if the vaccine is given on time to neonates and infants, it's actually infants, sorry, then the antibiotic prescription for otitis media, which is pain in the ear, has decreased dramatically. So these are vaccines that can bring excitement to the antimicrobial world. And important point that I'll highlight is there are a lot of ministries involved in the implementation of NAP. It's not just the human health and family welfare, agriculture, it's drinking water, sanitation, food consumption, fertilizers, all have to work together. So AMR has a lot of stakeholders at the country level and further down at subnational and national level. We need to have an AMR sensitive interventions which are specific for antimicrobial stewardship and teaching and training, but we can have antimicrobial sensitive interventions which are generic and help prevent any infection. I'll skip these for now. There is a role for everybody, including veterinarians. So what you have to do if you are a healthcare worker, we have already discussed lots, but for veterinarians, I would like to say that be AMR updated, be aware of what you are using, why you are using. Only if you are sure of the infection, you give an antibiotic, and coordinate with the human and the animal sector, with the human and the environment sector. So keep monitoring your data of these two sectors to understand where the resistance is coming from. Lastly, about the environment, there are a lot of questions we don't know. I would encourage you to follow the research in how AMR transmission occurs in the environment. And as research is increased, there will be strategies that come up to be implemented in the national action plans. So who has a role in preserving antibiotics is a poll I would like to take. Donna, can we take a poll for 1 minute? Donna?
Yes, ma'am, we'll take the poll.
Sure. You can answer this question. Who is critical? Doctors, health workers, vets, consumers, engineers of pharmaceutical plant, or all of them? Excellent. We can pause now, Donna.
Yes, ma'am.
So this is exciting because I am happy that you have all been listening. I have not just been droning, and you can see that it's all of us who have a role. So I would just like to conclude by saying AMR needs to be addressed in the socio-economic context of the country. The national action plans, NAP, AMR's operationalization need budget and governance systems and a very good One Health coordination across the human health, animal health, food safety, and environment health sector. It is a One Health problem and it needs to be addressed together. So we have to be united to preserve the antibiotics that we have. This is a report that has a lot of the discussions about AMR in India. I encourage you to go to our website and explore this report. If you have any further questions, please feel free to write to me or ask questions after this webinar in the Q&A section. Thank you for your patience.
Thank you, ma'am. That was an interesting and informative session, and it was a pleasure listening to you, ma'am. We have a few questions with us. Ma'am, do you need a 5 seconds break?
No, that's fine, please.
Yeah, okay. So the first question is, in the current COVID-19 scenario, over-the-counter antibiotic treatment for COVID-like infections are prevalent in our country. So is there any possibility that a superbug can emerge in this scenario?
It's a great question. And we've had a lot of discussion about AMR and what will happen during the COVID-19 pandemic to it. So there, I know even in the guidelines for COVID-19 management, there is use of antibiotic like azithromycin for if there are symptoms. So, but there are different evidences emerging. It has been seen that in the inpatient community, there is a large antibiotic use for managing patients so that they are not lost. But in the outpatient community, antibiotic use has decreased. People are more aware and conscious and don't want to take any medicine without asking the doctor. So it's too early to say what will be the impact, but definitely there will be an impact. And whether these two negate out or it magnifies the problem is something that has to be watched for. But whenever there is indiscriminate use, it is a cause for worry, is the note I will end with. So please avoid over-the-counter antibiotics and discourage people, even during the pandemic.
Okay. Ma'am, if you could please stop sharing your screen, ma'am, so that we can
Sure.
have a good view of yours. Okay, ma'am, the second question was, we got a good idea on reasons responsible for AMR and also about the One Health concept from your talk. In a developing country like India, from which point should we start acting to fight the AMR? From which sector should we start acting?
I think that's again a great question. One of the issues that the governments and global health is looking at is prioritization for the national action plans, because there is a lot of evidence For some areas, there is less evidence for the other, like I shared for environment. But I think whatever is available so far is adequate for us to start acting now. So wherever you are, so for example, if you are a veterinarian, you can start by making sure you don't give antibiotics for just growth promotion. If you are a healthcare worker, please make sure you get a diagnosis, or you are sure of it, and only then look for a antibiotic use. If you are a scientist, try to discover tests that can be used for point of care diagnostic testing so that antibiotic use can be prudent. If you're an engineer, look for technologies that can help to detect resistant bacteria quickly and act on them. So the on a global scale, on a policy level, evidence in some areas is lacking, and there is a move to gather evidence for that. But whatever is known is adequate to start acting now. So there are rules, for example, for strictly enforcing antibiotic use in hospitals through stewardships and drug therapeutic committees, also in farms, and through behavior change by this example of World Antibiotic Awareness Week in not just the common population, but also healthcare workers. So start where you are now.
Okay, thank you, ma'am. And one more question, ma'am. We are running short of time, actually. This is an interesting question from the side of participants. How can one associate with CDEP organization to conduct studies on surveillance
Oh, you're
or
welcome
any
to
other
write to
studies?
us. That's a great question. We would be happy to have your ideas and interests together with us. We have a lot of partnerships in India, and I welcome any of you who are interested to write to me.
Thank you, ma'am. So I think we are sharp on time. It's 4 p.m., ma'am. So thank you, ma'am, for your valuable time and your valuable talk with us, ma'am. I hope all of you enjoyed the session and did not face any technical error. We do apologize if someone faced any problem. As I said earlier, the recorded version of the webinar will be available on the website. So please do visit the Preventit website as well as our social media pages. Thank you, everyone. We appreciate you being here. Thanks again for joining us today. And we do hope to come up with an interesting topic next time. Stay safe, stay healthy.
Thank you.
Thank you,
Bye.
ma'am. Bye, ma'am.